Good evening, Dr. James. My name is Matt Powell. Could you please introduce yourself to the jury?
Sure. My name is Brian Shevis James. I'm a medical doctor. I've been practicing in the state of Florida since 1995. I'm board certified in anesthesiology. I'm also board certified, fellowship trained in interventional pain and surgery.
Thank you. Have you had an opportunity to treat a patient by the name of Danette Griffith?
Yes, I have.
All right. Can you tell us a little bit about how you fit into the puzzle of her care? What do you do?
I do interventional pain management. Danette Griffith came to see me as a new patient October 13th of 2011.
And what were the reasons that she came to see you?
She had neck, back, and left lower extremity pain.
Did you perform an examination of her?
Yes, I did. I took a history and performed a physical exam.
What did the history and the exam and whatever else you may have done lead you to conclude about Ms. Griffith's health condition on that day?
From my history and physical, I concluded that she had a diagnosis of cervical dystonia, cervical failed surgery syndrome, and lumbar radiculopathy.
Okay. Doctor, did you have an opinion at that time that she had pre-existing conditions in her body that may have caused or been important regarding your treatment?
I am not aware of any pre-existing conditions in Ms. Griffith's case.
All right, let me ask you this. When you took the history, what was the history you were provided regarding the causation of the conditions for which you're treating her?
Sure. Ms. Griffith, at the time I saw her, was a 46-year-old female who in 1999 was a pedestrian struck by a vehicle. In the year 2000, she had an anterior cervical discectomy infusion with partial relief. That's a surgery on the front of the neck where they put a plate and screws fusing the cervical spine. She had persistent neck and upper extremity pain as well as intermittent headaches. She was subsequently involved in a motor vehicle accident June 6th of 2007, which aggravated her neck pain. She also began having back and left lower extremity pain. She was diagnosed with cervical dystonia by Dr. Robert Hauser at USF. He gave her Botox injections with partial relief. Her pain is a constant sharp pain with tingling and numbness in the left leg. She has burning, throbbing, and spasms in the neck and back. It's aggravated by sitting, standing, walking, flexing, extending, and sneezing. It's better with rest, medications, ice, heat, and vital freeze. It's worse in the morning and night. There is subjective weakness in her arms and left leg. She has severe weakness in her neck. She's had swelling and temperature changes in her area of pain. She rates her sleep pattern as interrupted to poor. She has had chiropractic care, physical therapy, counseling for her pain, biofeedback, all with minimal benefit. Medications have helped the most. A TENS unit also is helpful. Surgery as well as injections have also helped. On the McGill pain diagram, which is a diagram of the human body, Ms. Griffith had colored in the posterior cervical spine, upper thoracic spine, and lumbosacral spine and rated her pain as a 9 out of 10 in those areas. She also colored in her left lower extremity and an L5-S1 distribution at a 9 out of 10. An L5-S1 distribution is an area of pain along the side and back of the leg. A lot of people refer to that as the sciatic nerve, the distribution of the sciatic nerve.
Thank you, Doctor. Tell us what treatment you started helping Ms. Griffith with.
I put her on a medication to help with nerve pain called Neurontin or gabapentin, also low-dose Valium for spasms, and a pain pill for the pain. I also at that date started her on hydrotherapy 30 minutes 3 times a week, provided a cervical traction to use gentle traction every evening at 30 minutes.
Let me ask you this. Let's go back to this cervical dystonia that diagnosis. Is that one of the most common causes of cervical dystonia trauma?
It is a etiology of cervical dystonia.
Okay. And could you tell the jury a little bit about how cervical dystonia manifests itself? What does the patient experience?
Persistent severe spasms in the cervical spine. Sometimes there are uninvoked movements of the spine and the muscles of the spine. Severe pain can also cause headaches from cervical dystonia. Those are some of the common symptoms with cervical dystonia.
And doctor, is it your opinion that the June 6, 2007 motor vehicle collision was the major contributing cause to her problems for which you were treating her.
Yes, that was my understanding according to the history obtained on October 13th of 2011.
All right. And Doctor, let's kind of switch gears and explain to the jury how often you see Ms. Griffith and what you do to help her.
I see Ms. Griffith on a monthly basis. I provide her with nerve blocks when her pain flares up. Most recently, we performed a lumbar epidural steroid injection on January 6th of 2014. I also monitor her hydrotherapy or home physical therapy, including the use of the TENS unit and her LSO brace. In addition, I manage her medications, which include Mobic for inflammation. She's also on Rilpax for her headaches, Marinol for nausea related to the pain and medications to control the pain, Valium for the spasms, as well as morphine for her pain. And that's what I see on a monthly basis for her.
Doctor, it sounds like some of those medications that you prescribe are pretty serious narcotics.
Yes, morphine is a Schedule II opiate.
And can you explain to the jury how it is that you manage specifically Ms. Griffith's use of these narcotics to make sure she's using them appropriately the way
We
you want?
monitor random urine drug screens. We have an opiate agreement with the patient. I also obtain every office visit what's called the Florida Query Report. It's a computer printout of all controlled substances obtained by each patient that I evaluate and review prior to seeing the patient to ensure compliance.
How has Ms. Griffith been a patient? Has she been compliant?
She has been compliant, and from her initial office visit, we were able to wean her off of the Dilaudid, which she was on initially, and reduce her overall opiate dosage.
Can you explain to the jury the value and the benefit of getting her off of Dilaudid and what it is?
Well, Dilaudid is 5 times more potent than morphine. What we try to do is from a multidisciplinary aspect, which means more than just opiates. We combine that with Dr. Hauser's treatments, with the Botox injection, with nerve blocks, with the home physical therapy, with the hydrotherapy, the braces, traction, TENS unit. All of these modalities, including opiate therapy, come together to give the patient a better quality of life on a lower dosage of medication than would be required otherwise if we weren't instituting these other therapies.
You mentioned that you've done some lumbar steroid injections.
Correct.
Epidural steroid injections.
That's correct.
Could you tell the jury how many of these you've done so far? And if you don't mind, walk us through one of them. What does the patient and you do?
She's had a total of 5 lumbar epidural steroid injections in the last 3 years. The procedure itself the purpose is to reduce inflammation in and around the nerve roots. In Ms. Griffith's case, she has foraminal stenosis in her lumbar spine, which is a result of large bulging discs. The foramen is a rigid bony canal that the nerve traverses through. When that nerve gets irritated, it swells and becomes inflamed. And in that Griffith's case, there's less room to accommodate that swollen, inflamed nerve, so it becomes pinched. When it becomes pinched, she'll get the radiating pain down the sciatic nerve and the L5S1 distribution. She will get spasms, severe and incapacitating pain. But in addition, when you press that nerve and put pressure on it, it reduces the blood flow and the nutrient and oxygen supply. So the nerve can become permanently damaged. The purpose of the lumbar epidural steroid injection is solely to reduce that inflammation and swelling in that nerve to take the pressure off of the nerve so that blood flow and oxygen supply can be restored, reduce the pain, reduce the spasms, and that we do those intermittently when she has a flare-up in her pain, which is pretty common when there's stenosis.
And can you explain to the jury how you do a lumbar epidural steroid injection? Is it done in a hospital? Is it a surgery? How complex and dangerous is it?
I do some nerve blocks in my office, in an office procedure suite. We also do them at a surgery center in an operating room. The patient is brought into the room, placed face down. The lumbar region is prepped and draped in the usual sterile fashion. 2% lidocaine is used to numb the skin with a 25-gauge needle, after which a 14-gauge 2E needle. The best analogy is it's similar to the end of an ice pick, is advanced into the epidural space of the spine. That's within the spinal canal. I then inject a mixture of depomedrol, which is a very potent anti-inflammatory steroid, mixed with lidocaine and a local anesthetic. The patient, the needle is removed, a dressing is placed, and the patient's brought to recovery. We sometimes do these under sedation because of the pain of the procedure. Some patients are able to do them just under local.
What do you do to make sure that, what are some of the risks of a lumbar epidural steroid injection?
Bleeding, infection, nerve damage.
What is it that you do to make sure that when you put in the needle in the spine, you don't hit the spinal cord?
I use fluoroscopic guidance, which is a large C-arm, so to speak, because of the shape of the machine. It shows me on a video monitor the bones, the location, to where I can have a precise location of the needle. I also, using a feel of touch to get the tip of the needle just in the epidural space.
So you're looking at a spine on your x-ray?
I am.
You can see the needle where it is?
Correct.
Okay. You mentioned also some other things like braces, traction. What kind of braces and traction is Mrs. Griffith?
That is a cervical traction brace, which is a rigid brace that she velcros onto her neck, the rigid components of it. It has a knob on the front that she turns for gentle traction to help stretch some of the muscles and ligaments out to take the pressure off of her spine.
When you say take the pressure off her spine, is that like pulling the bones apart so the nerves have more room?
Pulling the bones apart to some degree, as well as helping to stretch those muscles and ligaments at the same time. Over time, with repeated use of traction, it can help to relax those.
What's the effect of a muscle spasm or the cervical dystonia on the muscles? Because of the tighten up?
It causes them to tighten up severely.
And when they tighten up, how does that affect the nerves coming out of the foramen?
It can affect the nerves. It can cut off its own blood supply to the muscle, causing pain. There's a variety of problems that result from that.
When this happens, does it tend to have somewhat of a cyclical pattern where it's getting worse and worse until the pattern's broken?
It can. It certainly can. When you have a spasm, the muscle contracts so hard that the blood supply into that muscle is compressed, cutting off the blood supply, causing a buildup of lactic acid, causing increased pain.
What happens to the muscle tissue if it doesn't get oxygen in the blood?
It's damaged.
Okay. You mentioned some braces. Is that the same thing as the traction unit in your distance?
Yes.
Okay. All right. So let's talk about the TENS unit a little bit. What is a TENS unit and why does it work?
Transcutaneous electrical nerve stimulated. It helps at about 30 to 40% of the patients with some of their pain. It also improves blood flow to the skin and tissues right below where you put the stem pads.
How does Ms. Griffith use a TENS unit?
She uses it by placing the electrical pads on the area of pain, either in her neck or back, turning the TENS unit on, creating electrical stimulation of the skin and tissues deep to that to improve blood flow and to reduce pain.
Earlier, I think you mentioned that she had foraminal stenosis. Is that caused by trauma?
Most of the cases I see in my practice are caused by trauma.
And in this case, do you believe that the trauma was the motor vehicle crash that happened in 2007?
Yes.
Okay. Can you tell us a little bit about your observations as a physician about how Ms. Griffith is able to walk around, move, participate in normal activities in daily living?
She has difficulty with the activities of daily living depending on her pain level. It does fluctuate. Presently, as of the last time I saw Danette on December 23rd, 2013, with the treatment between the Botox injections, the nerve blocks, the durable medical equipment, the medications, her pain is tolerable a majority of the time.
Okay. Despite it being tolerable, do you think she's able to go out and get a job or able to walk far or drive a car well?
I don't think Ms. Griffith is capable of any type of employment because of aggravations to her pain, the medications, the pain levels themselves. I think that would be impossible for her to continue working without triggering incapacitating pain.
Doctor, I think earlier in your record you mentioned that she has incontinence.
Yes.
Can you elaborate what type and the cause of that?
Yes.
Sorry to bring up such a ugly subject, but it's important for the jury.
She has been incontinent of bowel and bladder for approximately 2.5 years at the time of the initial office visit. So now it's been over 5 years.
Will that ever get better?
I don't believe it will in her case.
What's the cause of incontinence?
There's a variety of causes. It could be trauma to the nerves in the back, infections, cancer. There's a large variety of causes of incontinence.
If she hasn't had any cancer or any infection, would it be your medical opinion that the cause of her incontinence is the motor vehicle crash of 2007?
According to the history I have, yes.
Is that within a reasonable degree of medical probability?
Yes.
Okay. Do you have an opinion within a reasonable degree of medical certainty as whether she has a permanent injury?
I do feel she has a permanent injury.
Okay. I'm going to ask you a question about causation. It comes from the jury instructions. And that is, did the incident, which is the 2007 crash, directly and in a natural and continuous sequence produce or contribute substantially to producing the injuries that you have said are permanent?
Yes, I do feel that that is the case for Ms. Griffin.
Can it be reasonably said that but for the incident, the permanent injuries would not have occurred?
I do think that's reasonable and a reasonable degree of medical certainty.
Let's talk about the future medical care and needs that you expect that she will need for the rest of her life. Can you just tell the jury about that?
Sure. I think she will continue to need intermittent Botox injections from Dr. Hauser's office at USF with intermittent epidural steroid injections, approximately 1 to 2 a year, possibly 3. Continued use of medications, continued use of the durable medical equipment, including the TENS unit, the traction. I would want her to continue active hydrotherapy, which I've been given her instructions on what to do in this heated pool on a daily basis. Also, stretching and home physical therapy would be necessary to be continued. And then I would see her on a monthly basis to monitor all of this.
And is that opinion within a reasonable certainty?
Yes.
Okay. And I'm trying to help quantify that. And would it be reasonable to say that the past 2 years of your care and treatment that you provided to her would continue on that sort of frequency and cost for the rest of her life?
Yes, I think that's a fair assumption.
Can you give us, and I don't know if you know what the costs are for your care and treatment on an annual or 2-year basis?
Actually, I can get my office manager can give you all of our billing information and what it's been, what her bill is specifically.
And whatever the bill specifically is it a fair and reasonable bill and in accordance with the normal charges of other pain management doctors such as yourself?
Absolutely. My charges, I ask my girls every year to review and to put them pretty much in the middle of what everybody else is charging.
All right, very good. I just would like to now, as all the questions on the case, I want the jury to understand about your education and training. And if you could please walk us through college all the way through your fellowship.
Sure. I went to LSU undergrad in Baton Rouge, graduated with a degree in zoology and pre-med. Went to medical school in New Orleans at Louisiana State University. Did my residency in anesthesiology at Ochsner Foundation. Did my subspecialty track in pain management and my fellowship rotation at Mayo Clinic, Jacksonville, Florida. After I completed that, I took the boards and passed them on the first time in anesthesiology, became board certified. Then subsequent to that, I took my boards in interventional pain and surgery and I'm board certified in that.
And could you help the jury understand what a fellowship is?
Fellowship is specialty training where I studied only pain management, interventional pain, and surgeries to treat chronic pain.
And I take it you're licensed to practice medicine in Florida.
Yes.
And can you tell the jury a little bit about what your practice is like? What type of patients do you treat?
I've been practicing in South Florida in the Sarasota area, particularly since 1995. My niche, more or less, is non-malignant spinal pain. Probably 85% of my practice consists of patients like Annette Griffith with severe spinal pain. Probably 5 to 7% cancer pain. The remainder are anything from arthritic pain that can't be treated by a rheumatologist or nerve damage pain from other sources, crush injuries, spinal cord damage.
Thank you, Dr. James. That's all the questions I have.
Thank you.
Thank you. Excuse me. Good afternoon.
Good afternoon.
Doctor, the treatment that you provided to Danae Griffith from the initial treatment up until today, those procedures that you just described to the jury, you performed such procedures on patients that were not involved in motor vehicle accidents, correct?
Yes.
All right. Now, you're basing your opinion on the cause of Ms. Griffith's complaints based on what she has told you, correct?
Correct.
All right. And she has not told you about the accident that we're here for, about what sort of accident it was. Do you have any idea about that accident?
No.
All right. And she didn't tell you about being involved in any other prior accidents before we were here, other than the pedestrian accident in 1999, correct?
Yeah, I have that in the history. The pedestrian accident in 99, and then the subsequent motor vehicle accident June 6th of 2007.
Yeah, that's the one we're here for. So she hasn't told you about any other accidents?
No.
All right. And she hasn't, well, she did tell you about a falling out of a chair incident. Is that correct?
She did mention that she's had several calls from the November 10th office visit.
Okay, since November of
2011.
11, she's fallen several times.
I think so.
Yeah, and that's not related to this accident, is it?
Well, with the pain she's having, lumbar radiculopathy, the foraminal stenosis, she does have intermittent weakness and 9 to 10 out of 10 pain in her lower extremity, which causes it to give out and can cause falls. So in that sense, it is related to the accident.
When she was sitting in a chair and fell out of the chair because of the Dilaudid she was taking, do you relate that to being due to this accident?
I'm not aware of that particular incident where, as you described, she fell out of the chair because she was taking Dilaudid. I don't have her on that.
I thought you said that you had weaned her off of Dilaudid.
Yeah, we stopped that relatively soon, and I don't have her on it presently.
Right. What did you prescribe her roxicodone?
Yes, she has been on that in the past.
Right. And so you began her taking Dilaudid, morphine, and Neurontin. Is that correct? When she first started treating with you?
No, that's incorrect.
In October 13th of 2011?
I don't have any Dilaudid prescriptions from that. I make a copy of every prescription that I write from this office, and in her chart, I am looking right now, and I don't have any Dilaudid prescriptions.
Okay, so you've never prescribed Dilaudid?
I have never prescribed her Dilaudid. I had her on oxycodone in the beginning, then we weaned her off of the roxicodone and on the morphine, which is less potent than either the roxicodone or the Dilaudid.
Okay. Now, I'd like you to assume that Ms. Griffith was involved in a rear-end motor vehicle accident of December the 24th, 2002, in which she was injured. I'd like you to assume that she was involved in a rear-end collision in which she rear-ended another vehicle with a Cadillac on September 27th, 2004, and sustained neck, back, mid-back, low back injuries. Now, taking those into account, those assumptions, do you still believe that the accident that we're here for of June 6, 2007 was the sole reason for Ms. Griffith treating with you?
I can't answer that with the information I have in front of me, but I would be more than happy to answer that if you could give me the records from those accidents and any treatment from between those accidents until the time of her.
I'm asking you to assume that as this is hypothetical as I asked you as being true.
I can't answer that again, that it's true. It may be true, it may be false. What I'd like to know is what was her pain level on June 5th, 2007, the week before this accident? Was she taking opiates? Was she under someone's care for those accidents still? Had she had those accidents, what kind of injuries were they? Were they just muscular? Or do we have an MRI to compare to this MRI? So there's a lot of variables here. If I assume she had those accidents, but they were treated and that pain resolved, then I would stand by the fact that the 6607 accident is the sole cause of her present pain and condition. But that's a hypothetical as well.
Right. So, in your normal practice, when you first meet with a patient, do you ask them to provide you with all of the medical, all of the accident history that they've been involved in?
No. Personal injury is a very small part of my practice. I would say less than 5 to 10%. So I'm more interested in the patient's pain. I'm more interested in what's causing the pain at that moment. Is it a herniated disc? Is it cancer in origin? Is there foraminal stenosis? What's causing a patient's pain so that I can go after that cause of pain and do the best I can to eliminate that and treat the patient as a whole to improve their quality of life. Whether they had, they fell off of a merry-go-round when they were 7 years old, that doesn't matter to me as much. What matters to me is the patient I'm seeing right now, what's the etiology of their pain, and what I can do to help either fix the problem, or if I can't fix it, to adequately treat it and manage it.
So, and the etiology of her pain is, as you understand it, is from what she told you, just from this accident, correct?
Correct, according to the history I took from the patient.
All right. You don't have hospital privileges in the area, do you?
No, I do my surgeries at a surgery center.
Okay. And you're not a doctor that goes into the Sarasota Memorial Hospital?
No, I voluntarily relinquished those when I started doing a majority of my procedures and surgeries at one of our surgery centers.
Of July 11th, 2012?
I had a cervical traction brace, but again, I didn't.
But that's not a C-collar, one of those soft
Excuse me, let me object. You're interrupting and cutting him off. He's trying to answer the question. I'm sorry.
I didn't prescribe a soft collar.
Okay. Well, the requesting physician at the time was Dr. Creeley. Were you aware that she was treating with Dr. Creeley?
That's the first I've seen of it.
Okay. So were you aware that she was treating with Dr. Creeley prior to treating with you?
I've got about 1.5 inches of correspondence. So I would have to go back through all of that. If I had gotten records from him, if that was obtained from my chart, then clearly I got records from Dr. Creeley.
Okay.
So at the time I was aware, it's just I've forgotten because it's been 3 years.
Okay. So in this Millennium Rapid Assessment of Drug Adherence Report, at that time in May of 2011, it states that morphine was detected but could not be matched to any other reported prescriptions.
I would ask you, sorry, I would recommend that you follow up with Dr. Creeley regarding that.
The findings that you've related about stenosis of Ms. Griffith, findings of stenosis can also be found from non-trauma related reasons, correct?
Correct.
All right. And those could be degenerative, correct?
Correct.
Incontinence can be caused from medications, correct?
Okay, rarely.
Okay.
I haven't seen it for medications.
Okay. Now, the cervical dystonia, you don't claim you're an expert in cervical dystonia, do you?
No, I do not.
And the etiology of cervical dystonia may be other than trauma in origin.
Correct.
And it could be an organic cause from the ganglion area of the base of the skull, correct?
Yes, it could be, and if that's the case, there are usually a host of other findings that this griffin doesn't have.
The time that she presented to Sarasota Hospital, that record that we went over of July 11th, 2012, does that correspond with the time period that she had seen you, July 2nd, 2012?
What was the date on that record?
Yeah, the Sarasota Memorial Hospital record was July 11th, 2012.
July 11th?
Yes, sir.
Yes.
And from my records, it looks like you had seen her July the 2nd, 2012, correct?
Yes, I did see her on July 2nd.
And at that time, you had prescribed Roxicodone,
Yes.
Valium, Zomig, and Maxol, correct?
That's correct.
The incident in which I was relating to where she fell out of a chair November 18th, 2011. I have this from your charts, and apparently it was a record from Sarasota Memorial Hospital, and it states that 46-year-old female who was in pain management allegedly fell out of a chair and injured her back. States that the patient required a second dose of Dilaudid in the emergency care center. She was on Roxicodone, so she already has a tolerance. I'm not surprised that she did not get terrific relief with only 2 milligrams of Dilaudid. And she understands that she's going to follow up with you. So looking at this record that's in your chart, do you see that Ms. Griffith did fall out of a chair?
Object to the former question. According to this history, she fell out of a chair and injured her back. I know you mentioned earlier that she fell out of the chair secondary to Dilaudid. I think that's incorrect. Because it doesn't mention here the cause of the fall.
Right, so when she was taking Dilaudid at Sarasota Memorial Hospital, that's what they gave her there?
Well, they gave it to her after she showed up with the pain, but she wasn't on that prior.
You'd agree that morphine is highly addictive?
All of these are.
Yeah. And are you working to cut Ms. Griffith back the dosage of her narcotics?
I have tremendously since she first saw me, but because of the magnitude of her pain, the objective evidence of the pain, her level of functioning with the meds, I don't think we'll be able to cut down much further. Pain does fluctuate, and we adjust the dosage accordingly. In some cases, and particularly in chronic pain, and in cases like Danette's, with the medication, she's able to function at a higher level. Some patients, when you place them on opiates, they function at a lower level. And those patients, they should not be on opiates. Ms. Griffith's quality of life is improved with the present medications, as well as the other modalities that we mentioned earlier. Her level of functioning is improved. Without the treatment, including the hydrotherapy, the home physical therapy, the traction, the tension, the braces, the Botox injections, the anti-inflammatories, as well as, yes, the opiates, she is able to function better. Without those, her pain is incapacitating to the point where where she's unable to participate in the activities of daily living and would require home care.
Are you aware of Ms. Griffith having any narcotic usage prior to you treating her?
No.
Thank you.
Doctor, you mentioned that cervical dystonia is most often caused by trauma, and then Mr. Fisher asked you about
Objective 4.
organic brain causes. What's wrong with the form?
It's not aware.
Okay. Do you remember a question about other causes of cervical dystonia?
Yes.
And one of them was something about the ganglia of the brain.
Yes.
Okay. You said that if you thought that Ms. Griffith's cause of cervical dystonia was from that, there would be other findings. Could you elaborate on that?
Well, depending on the ganglia involved, it would affect different bodily functions. That's simply it.
Okay. So it's still your opinion that it's caused by trauma, nothing else?
It is.
Okay. And earlier they talked about the falls. Was that related to some kind of dizziness and possibly use of medication?
I do believe on the November 10th, 2011 note, the first office visit after I initially saw Ms. Griffith, she was having some problems with dizziness, having falls as related to that dizziness. Dr. Hauser at USF was addressing that and working her up to investigate the dizziness.
And is it your opinion that the falls were caused by, or at least contributed to, by the motor vehicle crash in 2007?
I don't know what the cause was. I never got the final workup for the dizziness. I know it's improved significantly since then. Also, we've been able to reduce her medication significantly since then. So it could have been medications, it could have been an organic cause, it could have been trauma, but it does seem to have improved significantly.
Is it your understanding that Ms. Griffith was feeling fine 6 seconds before the motor vehicle crash hit her out? And it's an elaborate question. 6 minutes, 6 hours, 6 days, in other words, was she doing quite well before this motor vehicle crash?
According to the history I have, she was only having neck and upper extremity pain as well as intermittent headaches prior to that June 6, 2007 accident.
Okay. Doctor, there's some kind of like innuendo that you gave up your hospital privileges. Can you explain to the jury why you did that?
Sure.
Let me fix the question. There's been an assertion that you gave up your hospital privileges. Can you explain that to the jury?
Certainly. I started my first surgery center 13 years ago. We do our procedures and our surgeries in a surgery center created specifically for interventional pain management. Our staff is hand-selected to treat those types of patients with the types of conditions most commonly seen with chronic pain patients. The staff we have at our center is much more in tune with the needs, the special needs of chronic pain patients, much more than the general operating room at any of the hospitals. The efficiency is much better. The patients get better treatment because that's all we do there. 85% of our cases are interventional pain. Whereas you look at the staff at the hospital, they're fantastic, but they do cases everything from a total hip replacement to open heart surgery. Whereas our cases are more specific and have very specific needs. Just like anything else, when you treat the same type of problem, again, you become a specialist in that. I believe our surgery center is a specialist in treating surgery and surgical care of chronic pain patients. So we've had a 0 infection rate for our injections at my surgery center. That's not the case in the main OR. Nosocomial or hospital-based infections have been on the rise for the last 20 years. 0 patients out of over 100,000 procedures have had an infection from an injection of nerve block at my surgery center.
And Doctor, our surgery center is more economically feasible than going into a hospital?
Yes, it keeps the cost down tremendously, but what we're more in tune with is the patient care. We do get better patient care, in my opinion, at our surgery center.
There was also some sort of an innuendo that Mrs. Griffith was abusing drugs or narcotics. Let me rephrase it. There's been an assertion on cross-examination that Mrs. Griffith may be abusing narcotics or medication. Based on your care and treatment of her, how have you seen her as a patient in that regard?
Ms. Griffith has been a very compliant patient. I have approximately She has been very compliant. She has had random urine drug screens from our office, which has indicated compliance. Her Florida query report indicating where she's gotten any controlled substances has been compliant as well. There's been no indication to me on physical exam or during our office visits that she's doing anything out of line with what she had signed for the agreement with this office or within Florida statutes. And she has improved. I feel that she's improved significantly since our initial office visit. Her level of functioning is better with the treatment that we've instituted.
Do you think that she'll get any better than her condition is today?
I think she's plateaued at this point and has been at this level for approximately a year.
All right. And if we were to go down the road 5 years, 10 years, I don't want you to speculate. I want you to use your best opinion as a medical provider who's treated patients for over 20 years. What do you think her condition will be like in 10 or 15 years?
Well, I can't say that patients who've had traumatic injuries to the spine suffering permanent damage do have earlier degeneration of the spine. When I reviewed the MRI report, she does have bulging discs. They're damaged there. There's stenosis in the foramen. That will progress as she ages due to that trauma at a faster rate. So I can't really speculate. I know the treatment plan that we have for her right now, including Dr. Hauser's treatment, is keeping her to the point where she can't take care of herself at home. And I feel without that treatment, she would be unable to do that. I think that her pain, as she reports to me, is tolerable with this treatment the majority of the time, which is our goal. I don't think she will ever be pain-free.
Thank you, Dr. James. That's all the question for you.
Okay, ladies and gentlemen, we're going to go ahead and break and take our lunch recess. We'll be in recess until 1 o'clock, and we're going to end our proceedings today about 4:30.